Good evening, everyone. Today we have Dr. Nikitha presenting on the basics of grafts and flaps. We have Dr. Aditya Patil, sir, will be moderating the session. Uh, we welcome you, sir. Thank you for agreeing to moderate this session.
No problem. Start.
So we'll be discussing briefly about grafts and flaps in plastic surgery. So today's contents for the class would be history of plastic surgery, skin anatomy relevant to plastic surgery, classifications and indications of graft and flaps, assessment of a flap and the complications which we come across. So dating back to 1600 BC, which was the pre-scientific period, there were origins of forehead flap for nasal reconstruction, which were described as Susruta. Surgeons have been performing reparative procedures, which fall under the modern plastic surgery using the same techniques which were done even in the pre-scientific period. In 1500s, there was which is considered a scientific period. Tagliozzi has shown a flap which is used for the nasal reconstruction. And in the recent period of 1850s, which is 1900s, it's considered as modern period where there are cutaneous flaps and also myocutaneous flaps. Basics of plastic surgery, it combines three essential elements, which is form, function, and cosmosis. These are the principles which we routinely follow, that is, replace like with a like, respect anatomic boundaries, and minimize tissue trauma. And the main important, we have to preserve the vascular integrity. So the image which is shown in the slide is the reconstruction ladder, which is a schematic representation of decision making of a plastic surgeon. It was used as a guideline previously. Later, there was this reconstruction triangle, which had three components, which is flap, microsurgery, and tissue expansion. Currently, we are using reconstruction elevator, which means we can jump from the one mode to the other mode depending upon the expertise available and patient choice. Coming to the anatomy, skin is...
See, it's regarding the reconstruction ladder and reconstruction. This is going to be very important for your exam point of view. And there is nothing much to say in this, but except that basically it started from something very easy to something very complex. So this was done way back in history, where they thought that free flap was very difficult. Doing a pedicle flap was very difficult. Allowing something to heal naturally without even putting sutures was the easiest part. So that's why this pyramid and this whole reconstruction ladder was there, wherein if something can heal without intervention, that was considered to be the best. But nowadays we don't think that. If there is even a small wound, we prefer to close it rather than leave it for healing because of the scar. So it is not only about the expertise. Expertise also has increased, and availability of technology, microscopes, all these things have increased. So free flaps are being done more commonly. It is not wrong to first think of a free flap rather than doing a skin graft. So that is why the technique has changed. That is why people have given it a name of elevator instead of ladder, because you can jump to another this thing. So there's no need of choosing the easiest surgery, but it is basically of choosing the best surgery. That is the concept of this reconstruction ladder.
Yes.
Yeah, go ahead.
So coming to the anatomy of the skin, we already know that it is divided into three layers: epidermis, subdermis, and dermis. The most important point with respect to the plastic surgery is the blood supply of the skin, which is around which is the whole plastic surgery evolved. So it is supplied by a series of vascular plexus. These are arising from a named deep vessel, and then they divide into myocutaneous and fasciocutaneous branches. It is relatively straightforward to understand that anatomic blood supply of the skin. So deep vessels are like named arteries like aorta or common carotids. And fasciocutaneous would be like which travel through the fascia directly into the skin. Myocutaneous, they initially supply a muscle then reach the skin, perforate into the skin. There are a few septocutaneous also, which travel through the septum between the muscles and reach the skin. There are numerous subdermal and subfacial plexus, which are also important. So we'll be discussing mainly about graft, flaps, and microsurgery. Skin grafting is a closure technique used in dermatology and also plastic surgery. It is used to close the wounds which are created by removal, either by trauma or by the surgical intervention. It flaps and grafts are contrast in nature. Grafts we remove completely from the blood supply, whereas flaps they do have an attached blood supply which via pedicle. Skin grafts are less technically difficult but can be more time consuming, as it produces it creates a second surgical site. Grafting requires a good vascular supply for the survival of the tissue and a donor match for the acceptable cosmetic result. Donor sites also should match in thickness, color, texture, and adnexial structures. They should match the actinic damage of the graft as well. But it is important that area should be free of any infection or cancerous lesions. If possible, donor site should be non-hair bearing zone, which is more efficient. So classification of the grafts, they are divided into several categories based on composition. The main ones are split thickness skin graft and full thickness skin graft. The other one is composite grafts, which contain skin and another type of tissue, usually like cartilage. Indications of the grafts would be, in case of split thickness grafts, they are indicated for very large wounds which can survive on relatively avascular sites, whereas full thickness grafts are indicated for small avascular areas which are less than 1 centimeter, or for larger areas with a good blood supply. And composite grafts are indicated in situation where a donor site has lost underlying muscle or bone. So the most common composite graft in our surgeries would be cartilage used to reinforce the nose or ear. Contraindications for grafts, absolute contraindications for grafts include incomplete removal of cancer, active infection, uncontrolled bleeding. Relative contraindications would be smoking, anticoagulant medication, any bleeding disorder, chronic corticosteroids, and malnutrition. Split thickness should not be used near any free margins due to their increased risk of contracture. Full thickness should not be used on an avascular site greater than 1 centimeter. Routine complications of graft would be necrosis and revascularization. If the graft metabolic demands are too high and if the graft is separated from the wound bed, it could fail and it results in failure of the graft. So lack of wound bed or graft apposition, or after the graft, if there is any trauma or infection, hematoma or seroma formation, this will increase the risk of graft failure. Connection between the wound bed and the graft is very fragile and is prone to disruption by shearing forces. So meticulous hemostasis can help prevent the hematoma formation, and seroma should be avoided by with sutures and used in a large graft, as well as meshing the graft is also useful.
Are you going to be talking about how a skin graft heals?
So technique, we're not going to deal.
No, not technique. Not technique. How does a skin graft heal?
Heal, yes, sir. Yes, sir.
Or whether it's, are you going to talk about this in this seminar?
So I didn't get you, sir. Like
No, the
course of
imbibition phase, inoculation phase, all those phases. Are you covering it in some other seminar? Is it in this seminar?
Sir, I'm not covering in this seminar, sir.
Okay, at least read about it because it is important. What all you mentioned about sharing forces and about all those things. So that affects the graft till it reaches the revascularization phase. So there are 3 phases in skin graft healing. Read up about it. Up to revascularization phase, if there is any shearing force, the skin graft won't survive. That is important to know. And also just
Yes,
have you, what is the basic difference between split thickness and full thickness grafts? What does split thickness contain and how much does full thickness contain?
Full thickness has the entire dermis, sir.
Okay. And split thickness, how much
Split
dermis?
thickness, actually, it is again divided into thin, middle, and thick.
Correct.
So
Correct.
the compose only a portion of dermis, sir.
Do you know what is the thickness of a skin graft, of a typical skin graft?
Sir, 0.06 inches, sir. If it is very thin, intermediate
Yes.
is up to 0.12.
Correct. See, these are all very technical quiz-like questions. These don't help practically, but then these may
Yes.
be important for your Viva. That's why I'm asking.
Yes.
Okay, go ahead.
Yes.
And of course, one more thing is that in composite grafts, not just cartilage, we can use any tissue, whatever is there. But the entire graft should not exceed 1 centimeter in any dimension, not just length and breadth, even the thickness, even the depth. So, for example, composite grafts can be used on the finger also, fingertip injuries, when there is a amputation of the distal tip of the finger. When there is less than 1 centimeter of amputation of the tip of the finger, then we can scoop out the fat and bone and then replace the same thing directly on top, like a cap on the finger. That also is called a composite graft only. Yeah, go ahead.
Yes. So then comes a flap. By definition, flap is a piece of tissue with a defined blood supply, which which differentiates it from the graft, where a piece of tissue is fed from a blood supply and it's reimplanted to be absorbed into a different surrounding tissue. A well-designed flap should use minimal amount of tissue required and cause the least amount of donor site morbidity and maximize the return of form and function of the tissue defect, while simultaneously optimizing the flap's survivability to prevent the need for the revision surgery in the future. So flaps are usually classified based on 5 C's, that is circulation, composition, continuity, contour, and conditioning. Based on circulation, they are divided broadly into random and axial.
No, go back.
Yes.
Describe it, all those C's in short,
So,
in one sentence.
circulation would be based on the blood supply. Composition would be what are the contents of the flap.
What are the
Continuity
contents?
contents like a
Examples?
myocutaneous, osseous, like
Correct, go on.
yes, sir.
What else?
Fasciocutaneous, myocutaneous, osteocutaneous, omental flaps, that way, sir.
Correct, okay.
Continuity would be the way the flap is moved from one place to the other. Like, is it
Meaning?
local, regional, or distant flap, in that order?
Basically, it is pedicle flap versus free flap. Pedicle flap is not contiguous. Free flap is not contiguous. Pedicle flap is contiguous.
Contiguous, yes, sir. Contour
Okay.
would be the movement of flaps, sir, like transposition, advancement, and
Okay, this one is okay, no problem. What is
from
conditioning?
Bailey, I took this one. Conditioning would be the old techniques which they were using, like vascular delay, surgical delay, elevation,
It
so
is
that
not.
the
It is not.
flap would be
It is not an old technique. It is still used. It is a very important technique. In fact, whenever there is a free flap is not possible, and you need to do a big pedicle flap, and you are afraid that the pedicle may not supply the entire flap that you have raised, that time this wound delay is done. You condition the flap to survive on a low blood supply. For
Yes.
example, for example, if a pedicle is supplying a portion of skin which is say around 10 square centimeters, but you want a flap which is 20 square centimeters, and you're not sure whether that pedicle will be able to supply entire 20 square centimeters. So that time what you do is that you lift the flap, you raise the flap. It is done in different techniques. So the flap delays itself is a totally different topic, but flap delay is done so that that 20 square centimeters learns to survive only on this small pedicle. And once that it conditions itself to survive on a very low blood circulation, then we transfer it 1 week or 2 weeks later. So first a small procedure is done called flap delay, and then 2 weeks later, or sometimes even 3 weeks later, then the flap is transferred to the defect site. So this is called flap conditioning. You condition the flap to survive on low blood flow. Yeah, go ahead. That's why I wanted to know. I mean, you have written conditioning, but that is the meaning of conditioning.
Yes, sir.
So the flap you said will be raised and placed where for 2 weeks?
There only, where it was raised,
Mhm.
again it is kept back there itself. So what we are
Okay.
achieving by doing that is we're cutting out the lateral blood supply. We are
Yes, sir. Okay.
making the skin survive only on the pedicle which we have chosen. Because
Yes, sir,
normally
but
the skin would have. Yeah, tell me.
won't it get healed or derive its blood supply from the base again?
Not so soon. Not so soon.
Okay.
That is why in the first few days only. Generally, we wait only for 1 week. We don't wait for more than 1 week. Only in few occasions we wait for more than 1 week, around 2 weeks. But generally, it is 1 week. By 1 week, it won't develop. By 1
Okay,
week,
sir.
the flap is still surviving only on that pedicle, on the small pedicle.
Pedicle.
And by that
Yes, sir.
time, if the skin is not deriving enough blood circulation, you will see some skin changes that time itself without transferring it. Otherwise, what happens is that you've transferred and then the skin does not survive or part of the skin does not survive, it becomes a big problem. So if you do a flap delay, whatever skin does not survive, you will come to know before the surgery only. And then you can plan accordingly. You can take a slightly longer flap or broader flap, or you can choose a different pedicle altogether. Or you can discard
Okay.
that donor site, go to a different donor site. So different plannings can be done depending on how the skin behaves based on this conditioning. If it conditions well, then we can use the same flap. If it doesn't condition well, then we have to discard that flap.
Okay, sir.
Go ahead.
So based on circulation, they are divided into random flaps. That is their random pattern of blood supply to the flaps. So we rely on perfusion from subdermal vascular plexus. It's a there due to very low blood supply. These flaps we shouldn't exceed the length to width ratio of 3:1. The next one is axial flaps. These derive blood supply from a named artery, and to improve the survivability, axial flap will typically include tissue from a single angiosome. So a region of tissue supplied predominantly by a single named vessel is only considered. And the free flap would be separating the vessel and taking the flap to different location. Perforator would be multiple vessels. As mentioned,
Go back. Okay, random pattern flap, first of all, the ratio that you mentioned is not general. The ratio changes from body to body because every part of the body has a different way of circulation, different kind of blood circulation, different perfusion pressure. So 3:1 is not a general rule. If you had to make a general rule, the general rule is 1:1.
1:2.
The length and breadth ratio has to be 1:1. The flap has to be square. It can never be a rectangle. Only in few cases, in few parts of the body only, it can exceed 1:1 ratio. Only the face is an exception where you can go up to 3:1. 3:1 is not the rule, it's an exception. The general rule is 1:1. This is very important because if you raise a longer flap, if you raise a flap which is longer than it is wide, then it will not survive. Only 1:1 always survives. That is the random pattern flap. So don't mention 3:1. 1:1 is the general rule.
Okay.
Yeah.
Based on composition and the type of tissue involved, these are divided into cutaneous, faciocutaneous, only facial, musculocutaneous, only muscle, osteocutaneous, osseous, omentum, or bowel. Because large defects often require composite reconstruction. That is where we can use all these types.
Mm-hmm.
Based
Yeah.
on yes, sir.
Yeah,
Flaps.
go ahead.
Yes, sir. Based on the contiguity, they are broadly differentiated into local, regional, and distant. Distant, it could be either pedicle or free. So local flaps, they originate from the donor sites directly adjacent to the tissue defect, incorporating the donor site into the closure process. So while utilizing the local flaps, it's crucial to consider the resulting scar configuration, and its optimal placement within the boundaries. Then the regional flap would be in the same region of the as the defect, but not exactly adjacent to the defect. So these will be like wrist flap with from a forearm example, and the distant flaps would be pedicles or free. If we yes. So based on the contour or the different movement of the advancement, they are broadly categorized into advancement, transposition, and rotation interpolation. Other techniques would be waltzing, crane principle, and free. Advancement is just taking forward the flap, whereas transposition is taking it to a different position with a pivot movement. A rotation would be a complete angular movement of the flap. Interpolation would be taking it through the tissue into a different zone. Waltzing of a technique can be categorized as it's basically like it's a staged procedure where we move the flap from one position to the other, like walking stock kind of movement. It is so the pedicle from the source to the target size by periodically moving it and finally anchoring it to the target site. Crane principle was a previous old technique where a pediculated flap was used to transport to the raw area, but again return to the original area in the later time. So for only a brief moment of time, we are using the flap in that zone.
Why?
Sir, it's till we plan for the proper flap, sir.
Why can't the flap be done in the first place? What is the meaning of crane principle? Did you understand, or are you just reading? Did you understand the concept of crane principle? These are all very interesting things. These may not be done practically now. This is again a very old technique. Even the waltzing and crane principle, both of them are no longer done when free flap is available. But whenever free flap is not available, these two concepts are still used. They may be a slightly advanced thing for you, but it is a very interesting thing to know. What is crane principle?
Basically, even when the subcutaneous tissue is lost, in order to regrow it or revascularize that small zone of area, we use this, is what they have mentioned, sir. Right?
No, I know what they mentioned. Have you understood it? Is my question. If you've not understood, tell me, I will explain.
I understood to this extent, sir. Like you place a flap over there, get the reaction, make a bed there, then remove the flap from there, and we can use for grafting the previous zone.
Yes, exactly. See, the main crane principle is generally used when bone is exposed. Whenever bone is exposed, can graft be placed? No. Whenever the periosteum is not there, graft cannot be placed directly on bone. So that is why if you don't have an option for a flap which is there nearby, for example, a scalp defect, whenever there is burns over the scalp or whenever there is a necrotizing fasciitis of the scalp and the entire skin has been removed and the bone is bare now, you either need to do a free flap or you need to do a big pedicle flap. If free flap option is not available, if someone is not available to do a free flap, you need to do something called as crane principle, where you can take a pedicle flap, place it over the defect area, wait for 3 to 4 weeks. The new granulation tissue will grow from the pedicle to the bone. And then you place the pedicle flap back to its original place. Till then, you will get some granulation tissue over the bone. And over this granulation tissue, you can do a skin grafting instead of doing a flap. Okay, so it is a technique where flap cannot be done for whatever reason. Either the surgeon doesn't know or patient is not in a position to undergo a flap. That time you can do a crane principle to protect the bone. Because if the bone is kept open for a long time, it undergoes osteomyelitis. It will become dry and lusterless. So you need to keep it covered with some kind of flap. So this crane, why it is called crane's principle is that because it works like a crane, like a crane which is there in construction sites. It takes tissue from one side, goes to the defect area, deposits granulation tissue there, comes back to its original position. It works like a crane. That is why it is called crane principle.
Then what about making holes in the bone to expose the medulla so that
It is not.
granulation
It is
tissue
not.
develops in?
It is not that effective. It is not very
Okay,
very
sir.
effective. And creating holes and even removing the outer table, all these are last resort options. So instead of that, this pedicle flap will help you keep the outer table also, inner table also. No need of making burr holes. You can keep the bone intact. And of course, crane principle is for a smaller bone defect. If you have a big defect, like almost 2/3 of the scalp is calvarium is kind of exposed, then making holes is the only option if you don't have a free flap.
Okay.
So yeah, that is only for larger areas. Smaller areas, this will work better because you don't need to remove any bone. You can preserve all of that bone. Like I said, again, it's a very historical concept, but it's a very interesting thing to know. If Nikitha put some pictures, we would have come to know more easily. Because only discussing on by words, it is very difficult to describe these techniques. And what is waltzing?
Waltzing is like,
Don't read out. Don't read out. Tell me what you
yes, sir.
understood.
So, for example, if we have a defect which is very far from the flap where we wanted to harvest,
Hmm.
so we take the flap, first move it close to the defect, but not exactly into the defect. Then again, next in the next sitting, we move it furthermore close to it. Then slowly, finally closing the defect, sir, in a multiple.
Yes. Why is it called waltzing? See, some terms, no,
There is a
don't memorize words as it is. Try to have curiosity why they are called that. Then you'll remember better. You will either come to you'll get the information that okay, this is because of a surgeon's name, or because of something, or because of something that happened in history, or because it is associated with something like crane principle. Crane principle is because it works like a crane in a construction site, right? So what is waltzing? What is waltz?
A type of dance
Waltz,
form, sir.
yes, exactly. Waltz is a form of dance. Like how if you see waltz, the dance, you will come to know how this works. Basically, um, I mean, you can Google up and see later on YouTube how a waltz dance is. This flap resembles that dance. That is why it is called waltzing. Do you know slinky, the spring-like thing which children play?
Yes, sir. Sling.
So slinky, which we keep on the top of the stairs, and that spring keeps on going down and down.
Yes, sir. Yes, sir.
So it is basically that concept that you take a flap from somewhere, like for example, the defect is in the face, and the entire arms, the thorax, abdomen, back, everything is burnt for the patient, but you need a flap to cover on the face. So where will you take the flap from? The only flap is available in the leg, for example. So then leg or thigh, for example. So you raise the flap from the thigh, you attach the flap to the abdomen. Okay, now the flap is connected to the abdomen and thigh. So 3 weeks later, you detach it from the thigh, and that part you move it to the chest. Right. So once 3 weeks it gets stuck there, then you detach the abdomen part and you move it back to the face. Are you getting my point? I mean, if there was a picture, it would
Yes,
have
sir.
been easier to say, but it's like a slinky. That's how a waltz happens, the dance happens. So that's why it's called waltzing. Again, now this is all very historical and very obsolete kind of thing. No one does this, but interesting to know because generally all Viva questions are based on interesting things. Okay, next.
The next one will be conditioning. As sir explained, by different techniques, we are trying to kind of induce ischemia into the flap and make it be more viable and more sustaining in even adverse conditions, and using it for the flap later on. Based on composition, faciocutaneous flaps are again classified by Cormack and Labate into 4 types, depending upon the composition and the blood supply. So type A would be, it will receive the perfusion from multiple perforators entering
You
its.
don't need to go deep. You don't need to go deep into this because this concept is not very useful even for us. These are just more bookish concepts. So maybe you can memorize for your exam, but otherwise you don't need to go into depth into this. We don't use this even now for any decision planning. But whereas for myocutaneous flaps classification is important. Faciocutaneous flaps classification is not that important.
Okay. Shall I just read through it, sir, or skip it?
No, you can skip it. You don't need to spend time over this. But if you have put Mathis and Naik, yeah, so this is important.
Yes. So muzzle and myocutaneous flaps, they actually organized into 5 types based on the vascular supply. So type 1 would be like there is a single dominant vascular pedicle coming into the muscle. So it supplies the complete muscle. Type 2 would be one dominant pedicle and also multiple minor or segmental pedicles. Type 3, there are 2 dominant pedicles, one of which is from a named artery and it completely supplies the muscle. The other could be the secondary branch of a named artery. Type 4 would be all the segmental branches to the muscle. Type 5 would be an dominant artery and multiple segmental arteries. So
This is important. Why I will tell you, because for example, the first example that I've given below for the type 1 gastrocnemius. So gastrocnemius has a dominant supply which is coming from proximally. There is no distal blood circulation to a gastrocnemius flap. So that helps us plan the flap because we can now use the gastrocnemius only with the pedicle on top. We can only detach the lower portion and turn the gastrocnemius flap upwards. We cannot do vice versa. We cannot cut the upper portion of gastrocnemius flap and bring it downwards because the dominant blood supply is on top. And this is very important. This is a very important part of anatomy. Entire body has muscles, and all those muscles are categorized in these 5 types. We have to know, as plastic surgeons or as anyone who is doing flap, to know what is the blood supply, where is it coming from, whether it has a dominant blood supply, whether it has a minor blood supply, or whether it has a segmental blood supply. For example, if you see type 4, it's a segmental blood supply. So tibialis anterior is of no use in any reconstruction because we cannot detach it from anywhere because it does not have a single dominant blood supply. It has a segmental blood supply throughout. So you cannot elevate the muscle from proximally also and from distally also for coverage of any defects. So tibialis anterior is almost useless for reconstruction. So because it has a segmental blood supply. For example, next you have mentioned trapezius, or for that matter, even pectoralis major. That also is a type 2 muscle. So, do you know the blood supply of pectoralis major? Nikitha? Nikitha?
Sir, multiple perforating branches of mammary arteries, sir.
No, of pectoralis major muscle, not mammary arteries. I'm not talking about breast. I'm talking about pectoralis major. Pectoralis major's main blood supply is thoracoacromial artery. So that is a dominant blood supply. So we can do the pectoralis major flap based on this artery. But sometimes if there is a sternal defect or sternal dehiscence after cardiothoracic surgery, we will have to cut the dominant artery and use the M, whatever M is mentioned, those are minor arteries. So those are the minor pedicles. So we use the sternal intercostal arteries, which the pectoralis major is turned on these arteries. The dominant artery is cut. So if the muscle has a dominant and minor pedicles, even the dominant can be cut if it is based on minor pedicles. But if the muscle has only a single dominant artery like the type 1 muscles, then we cannot do any other way. We have to cut the distal portion of the muscle and take it proximal. So the movement of the muscle or how to, the arc of rotation and all those things will depend on which type of muscle you are using. So that is why this classification is useful, but whereas fasciocutaneous does not have any practical application. Go ahead.
Yes. So indications for a flap transfer are generally when the tissue defect cannot be closed primarily and it is not appropriate for a skin graft. So, and contraindications, absolute contraindications would be flap transfer for wound closures, which are Can you hear me, sir?
Yeah. Are you on the next slide?
No, sir. In the same slide.
Okay, fine.
So absolute contraindications to a flap transfer would be closure of defect which are possible by primary closure or a skin graft. Relative contraindications include active infection and residual malignancy of oncologic reasons.
I don't. Where have you picked this up from? Indication,
Sir,
contraindication?
I get from Stat Pulse, sir.
Contraindication, you're mentioning that if something is, you can close by primary suturing, why would you need a flap? It is not a contraindication, it's not required only. That is one thing. And relative contraindication, I don't agree with the presence of infection. Severe infection, yes, but minor infection, in fact, flap sometimes helps in reducing infection. If there is an infection, for example, there is a tibia defect and the bone is infected, there is osteomyelitis. If you do a fasciocutaneous flap or even a free flap, the infection reduces. Why? Because the flap carries its own blood supply. Whatever antibiotics you're giving through the mouth or even intravenous form is not reaching the bone, not reaching the exposed bone, and that is why it is osteomyelitic. Once you do a flap, it carries its own blood supply, and therefore it carries the antibiotics till the bone, and that is how the infection starts resolving. So infection per se is not a contraindication. Severe infection is a contraindication, yes, but mild infection, sometimes flap is beneficial to reduce that infection.
Okay.
Can you tell me what are the parts of the body where skin graft cannot be placed? Because that will become an indication for graft. Where can a skin graft not be done?
Joints, over the joints, sir.
Okay. And only joints? Everywhere else the skin graft can be placed?
Any bony prominences, like basically
Malleolus.
Bone. No, forget just bone. Bone is, it covers everything. Bone. What else? Skin graft cannot be placed on the bone, accepted. What else? And that too you have to be even more clear because skin graft cannot be placed on bone which is devoid of periosteum.
Devoid.
If there is periosteum, you can still do a skin grafting over the bone also. It is not recommended, but you can still do, and it will survive because periosteum has its own blood supply. Okay, so apart from bone, what else?
Cartilage.
Correct. Again, cartilage which is devoid of perichondrium. What else?
any area where there is going to be a lot of pressure, sir.
See,
The
that is not, you're talking about something which is not recommended. Yes, skin graft should not be done in area where there is too much pressure. But I am talking about whether skin graft can be done or not, whether the skin graft will survive or not is the question. Like for example, you can do skin graft on the plantar aspect of the foot also. It will survive, but it is not recommended because again it will ulcerate because of the pressure. That is correct. But then I want to know what are the areas or what are the parts of the body where skin graft cannot be done at all. The skin graft won't take at all. One is bone is correct. Cartilage is correct. What else? Quickly, they're all common questions.
So, palms and soles would be considered, sir.
No, tendon. When there is tendon exposed also, you cannot do a skin graft. Tendon which does not have a paratenon. Tendon which is exposed. A tendon, bone or cartilage which do not have their coverings, they cannot be skin grafted. They will require a flap. Either you have to excise, you must have seen so many diabetic foots. So when you're doing skin grafting, if the tendon is exposed, what do you do?
we go for a flaps only, sir.
Okay, but if you still want to do skin grafting, what do? You snip off the upper part of the tendon, no? You either cut the tendon off completely or you snip off or you shave part of the tendon, hoping that the inner
Yes.
tendon will be slightly more vascular. Right? So you don't
Yes,
put a skin graft directly on a tendon anytime because it won't take. It will give away. What is one bone in the body where skin graft can be done without periosteum also? Any guess?
Ilium, sir.
Where?
Ilium.
Why?
Basically, it has
You're
more.
talking about ilium, pelvic bone ilium?
Yes, sir.
Why would you do a skin graft there? I'm talking about
Nasal.
exposed bones bones which can be exposed in general, maybe hand, foot, or chest, or back, or face, or wherever. Any bone which can be exposed. Ilium is never exposed in any kind of injury, unless it's a massive injury. But ilium is not the answer. Any other bone which you think can take a skin graft without periosteum also? Anyways, read up about it. Tell me tomorrow.
Yes.
Go next.
Is it nasal bone, sir?
Slightly correct. I wanted a slightly more broader answer.
Okay. I'll
Okay,
find out.
anyways, okay, it is better you guys find out. It'll be fun for you to read.
Yes, sir.
If you don't find it, I'll let you know tomorrow.
Yes, sir.
Okay.
Recent advance is the microsurgery, which usually uses extra magnification and specialized instruments to repair the intricate structures in the body. Right now, it is into the reconstruction, reimplantation. Allotransplantation is from the different, complete different graft, and super microsurgery, which is involving neurovascular structures and also lymphatico-venous anastomosis. So, post-op care of a flap. We are supposed to keep the patient wet, warm, and comfortable. This is the dictum. Wet by maintaining the proper fluid balance, keeping him hydrated. And warm would be, can anyone tell me what is bear hugger device? We usually see it in our hospital, but we don't know its name.
That to make the temperature intraoperatively, we use that to warm bags.
Warm blanket.
Blanket.
So, yes. So the device which pumps the hot air into the warm blanket is called bear hugger device. And the third one would be analgesia. So the patient has to be comfortable. There shouldn't be a lot of pain. And the flap check, it's usually a clinical examination.
Go back. Why all these are required? Why wet, why warm, why comfortable?
To maintain adequate perfusion into the flap, sir. So overall circulation has to be
and answer to the point, no problem. So
yes.
For adequate perfusion, you require fluid balance. Good. Why warm?
Sir?
Why warm? Why the bear hugger device is required? Why the warmer is required? Quickly, all
even in case of hypothermia. Yes.
Yeah, correct. Yeah, that's the answer. You have just answered quickly. Because in cold, whenever it's cold, the peripheral arteries or the arterioles will undergo vasoconstriction and the perfusion won't be there. Why analgesia? Apart from, of course, patient should not be in pain, that is one thing. But why for the flap analgesia is important?
Sir, local immunomodulators to decrease them.
Sympathetic activity. What does sympathetic activity do?
Vasoconstriction.
Correct. That's it. Concept should be clear in your mind. Next.
Yes. So the clinical examination to check the flap to assess its vitality. First, we need to look at the color of the flap, whether it is turning pale or in the normal color. And the second one would be the warmth of the flap. With a good perfusion, it has to be according to the body temperature. And capillary refilling, we have to check whether the capillary refilling time is within normal limits or not. We can do a pinprick test or a scratch test in order to see if there is any fresh bleed or is there any dark colored bleed from the flap. We can also use a Doppler evaluation to check at the pedicles flow and arteriovenous signals.
What is the normal capillary refill time?
5 to 10 seconds, sir.
5 to 10 seconds.
Less than 3 seconds.
2 to 4 seconds.
Less than 3 seconds.
Less than 3 seconds. 10 seconds are all been gone. Flap is also gone and the patient also will go. Okay.
Yes.
Your own nail bed you can press and see, no, Nikitha? When you press your nail, you can press your own nail bed and see when will the color, when does the color comes back? Does it take 5 seconds? It is
No, sir,
instantaneous,
no, sir.
less than 3
Instantaneous.
seconds. That is the way to look for capillary refill. Of course, in the flap is a different thing, but capillary refill, it's always less than 3 seconds. Even the flap has to come back within 3 seconds. If the capillary refill is more than 3 seconds in a flap, there is some problem, and you will have to re-explore.
Yes.
Go ahead.
Coming to the complications, first we need to look at the donor side complications, because these are the things which we usually be neglected. So it could be infection of the donor site, scarring of the donor site, functional impairment, and some specific complications like pathological fractures when you do a bone grafting, like bone harvesting, and also abdominal hernia when you are doing this rectus muscle flaps, and foot drop in case of peroneal nerve injury during a fibular flap.
Why pathological fractures? Can you give me an example?
Sir, when we do an iliac crest free flaps.
Okay.
Sorry, sir,
don't
not
think,
iliac crest. I'm sorry, sir. Bone. In the case of osteocutaneous flaps, sir, they are prone to the pathological fractures, is what they have mentioned.
They have mentioned, I know, Nikitha, but where? Tell me one example.
If you do a radial forearm flap, then if the patient has a fall, he has more chances
Okay,
of
you're digging yourself into your own hole. Now tell me, what is a radial forearm flap? What is the type of radial forearm flap? What does it contain?
I don't know the
What components does it contain? You had mentioned, no, skin, fascia, fasciocutaneous,
Sir,
muscle, myocutaneous.
osteocutaneous, sir.
Radial forearm flap.
Yes, sir.
Myocutaneous.
No, both are wrong. It's a fasciocutaneous flap. Radial forearm free flap is a fasciocutaneous flap. There is no muscle that we're taking. It's not a muscle flap. It's not a myocutaneous flap. We are not taking any bone during radial forearm flap. We are taking only skin and fascia. So it's a fasciocutaneous flap. In a very, very rare conditions, we take a radial bone, part of the radial bone along with the radial forearm flap. Very, very rare cases. Like there are only case reports about this. So we can take about 1/3 of the circumference of radial bone, and we can reconstruct, for example, say the maxillary bone. If the maxilla has been removed because of cancer, the maxilla can be reconstructed with a small piece of radial bone. That time pathological fractures can occur, and whenever we take this bone, we already plate it preemptively to avoid the pathological fracture. This is probably the only place where pathological fracture can occur. Iliac crest bone graft, even if you take, iliac bone does not undergo pathological fracture. Fibula bone, anyway, you're taken an entire segment of bone, so there's no question of pathological fracture. Right, so the only one small rare scenario of pathological fracture is radial bone. They may have mentioned in the textbook, but you don't need to mention this because you are simply digging yourself a hole.
Okay, sir.
Zoom meeting exit కొట్టేది.
Abdominal hernia, why?
Sir, in the case of rectus abdominis muscle flaps, sir, myoflaps.
How many types of rectus abdominis muscle flaps are there? Have you heard of DIEP?
Yes, sir. Yes, sir.
Okay, what is the difference between rectus abdominis muscle flap and DIEP? Do you have a timing for this seminar? Do we need to finish in some time?
Usually 1 hour, sir.
1 hour. Okay, quickly answer this question. I will not disturb you again. Do you know or you don't know? I'll let you know.
No, sir. No.
So DIEP flap is somewhere where we don't take part of the rectus fascia. We take only the perforator of the deep inferior epigastric artery. So that's why their abdominal hernia will not occur, because we're not taking any part of the fascia. So these are some catch points where if you mention this, no, the examiner may go into more detail. Why, where, what are the exceptions and all those things. So it is better to stick to the smaller points, or if you are mentioning that, you should know where it occurs. For example, you said foot drop occurs in fibular flap harvest. That is correct. So like that, you should know abdominal hernia, where it occurs, and which type of rectus abdominis flap does it not occur. So in
Okay.
DF flap, it does not occur. Yeah, next.
Sir, what we will take in this DIEP, sir?
Only skin and fat. We're not taking any fascia, we're not taking any muscle. Whereas in rectus abdominis muscle flap, the entire rectus abdominis muscle is taken along with the fascia. And because the fascia is taken, there's a big defect there through which hernia can occur. That is why mesh has to be put.
Yes.
Later on, whenever you guys are free, you can come and I'll show you pictures. You'll be able to understand.
Yes, sir.
Yes.
Yeah, okay.
Flap complications. These are usually vascular compromise, either because of the venous obstruction or for the arterial insufficiency, and hematoma formation or infection. So, recent studies have shown that most of the time when we find vascular compromise and take the patient for the re-exploration, venous outflow obstruction is seen in majority of the cases in comparison to the arterial insufficiency. So it is now advisable to like wait and watch even if there is some vascular compromise, because it could be venous obstruction and it could get relieved. Temporarily, we can use some some methods like leeches and prophylactic anticoagulant measures.
How many more slides are there?
One more slide, so that's it.
Okay, so then we'll go into detail about this. What does a leech do?
Sir, a leech usually it releases a anticoagulant kind of material.
And that is how it helps? No. How does a leech help? What is venous congestion? Basically, the flap is getting supply from the artery, but the vein is not draining properly. So the blood is getting accumulated into the flap. Right? So the blood has
Yes,
to be
sir.
drained somewhere, somehow. Either you go back, re-explore and do the venous anastomosis once more, clear the clot and redo the venous anastomosis, or else you drain out the venous blood somehow. So one way is by doing a leech therapy, where the leech will suck out the blood. So whatever blood the artery flap requires is coming to the artery, but instead of going back to the body through the vein, the leech is sucking it out. And that is how the flap will survive. That is why leech therapy is important in a flap. But otherwise, this is the only other way. But apart from this, surgical is the only best way to, kind of deal with the venous outflow obstruction.
Do we routinely use this at leeches, or it is only?
Yeah, no, not routinely. Of course, whenever there is, we cannot do a venous anastomosis again. For example, if there has been a radical neck dissection, and if we have only a stump of IJV to anastomose, we have anastomosed the vein to IJV, but IJV entire thing has got thrombosed, for example, because of the cancer or because of any other reason. In a radical neck dissection, we will not find any other veins to anastomose. So that time we use leeches, so that somehow the flap survives. And we only delay the flap to get necrosed. By leeches, what we are doing is we are only prolonging the time for the flap to heal. And we are expecting that by 5 days, 7 days, the flap develops new venous outflows from the bed of the wound. And from there, the venous outflow starts. That is our hope. But generally, 90% of the cases, even leeches don't help. Leeches are just a way to buy time. We are just prolonging the death of the flap. So leeches help in some cases, not in all cases. Leeches are more commonly used on finger reimplants. So because finger reimplants don't require too much of blood supply and too much of venous outflow is not there. So that's why we can take around 2 or 3 leeches per day is enough. And till by around 5 or 6 days, that finger which is reimplanted develops new venous connections and it starts draining, and then we can stop the leech. That leeches are more commonly used for the finger rather than bigger flaps.
Okay.
And we have to use medical leeches, not any regular leech. And it is not because of the anticoagulant property, it is for the blood sucking property.
Okay.
Yeah.
Sir, in case of hematoma, it requires immediate evacuation. chronic complications would be scarring, contracture, numbness, and persisting pain, and abnormal hair growth or loss in the flap, and color or texture discrepancies. These are the long-term and chronic complications. There are newer innovations like nanotechnologies and tissue engineering and 3D bioprinting currently, which are in the studies, which may also enter into the reconstruction ladder sooner or later. That's it. Thank you, sir.
Okay, done. Great. Any other doubts if you have, you can ask me.
Hello,
Yes,
Yeah,
sir.
Vinod.
sir. This full thickness graphs which we using, we need to cover that primary area also, sir.
No. The full thickness grafts are completely full thickness, so they're not going to heal on their own. You cannot cover it. You have to stitch it up. You have to suture
Yes,
it.
sir. Whatever I mean is, yeah.
You have to suture it.
Okay.
You can leave it for secondary healing. It will leave a very bad scar, and it will take very long time to heal because it's not like a split thickness skin graft. Split thickness skin graft, there is part of dermis is still there, so it
Yes, sir.
can
Yes, sir.
regenerate. But in full thickness, you have removed the dermis also. So what you're seeing down is directly fat or subcutaneous tissue. That will
Yes,
not
sir.
heal on its own. If it's a small, very 0.5 by 0.5, something like that, then maybe it'll heal. But otherwise, suturing is always better. When I take even a 1 by 1 centimeter full thickness graft also, I finish by suturing it.
Okay.
However big it is, it has to be sutured. Or
No.
it has to be covered by a split thickness graft. The donor side of the full thickness graft can be covered with a split thickness graft.
Yes, sir.
Sir,
Any
you had
other,
told about Mathis and Nahai classification. In that, the tibialis anterior was having only the segmental supply. So any muscle which is having only a segmental supply, so they are never going to be useful in any kind of flap reconstruction,
in
sir.
very rare cases, for example, tibialis, and like you have a patient who has such a massive exposure of the tibia, and he has no other flaps available anywhere, and tibialis anterior is the only muscle which is left. Then you can turn it on the segmental blood supply itself. You cannot cut the segmental blood supply, then you can't take it proximally or distally. You can turn it laterally. Along the segmental. So it will give you, it will just turn like what, 2 centimeters, 3 centimeters. So if there is a long part of tibia which is exposed, which is only 2 centimeters or 3 centimeters wide, and you're not able to do any other flap, that time it can be used. So it's not like never, but they're not useful. They are not very useful flaps. Most useful flaps are those which have at least one dominant blood supply. They may have one dominant or multiple segmental, that is fine. But at least if one dominant is there, you can use that as the axis of the flap, and then you can raise an entire free flap on that. But if the flap has only minor pedicles or segmental pedicles, you cannot.
Okay, sir. And to know that whether a muscle has a dominant and a segmental supply, it's all just we need to know about each and every muscle in detail, or is there any?
Yes, it is already explained. It is already, all muscles are already categorized.
Already.
So yes, all of them are categorized.
Okay, sir.
You don't need to check, you don't need to do a Doppler, nothing. All of the muscles are already categorized. By embryology, they are categorized because they, all muscles develop in a certain way, and they develop blood circulation in a certain way compulsorily.
Okay, sir.
That is why I'm talking about muscles, because muscles have predictable and reliable blood supply. You know that if you say gracilis, it is going to be type 2, for example. So if you say trapezius or pectoralis major, it has to be type 5. So something like that. Type 2, sorry. So something like that. You know that this muscle is belonging to this category beforehand, because every muscle by embryology grows in a certain way only. But fascia and skin don't work that way. That is why the earlier classification, Cormack-Lamberti, is not very useful, because it's not at all predictable. It is not predictable, and it's not useful in any planning. You have to check beforehand with a Doppler or with a CT scan, CT angio, to check if the flow is okay. That is why Mathis-Nahi is very important, even now.
Okay.
Yeah.
Sir, Mathis-Nahi's even fasciocutaneous classification is also, sir. Is that also same thing, sir?
No, none of the fasciocutaneous flap. You will let it be given by Mathis-Nahi or let it be given by Aditya Patil. It doesn't matter. Any
Okay.
person who is giving classification of faciokidness flaps will not work because embryologically, faciokidness flaps do not follow a certain pattern. They
Okay,
develop
okay, sir.
slightly randomly, and
Yes.
they're not predictable. That is why, but muscles are not like that. Muscles definitely follow a certain pattern. That is why muscles are predictable. That is why anyone who gives a, I'm not talking about Matthews or Nahai as a name. Anyone can give a classification of muscles, but
Yes,
whoever
sir,
has given
understood.
it, it will work for muscles. It will not work for any other body tissue.
Yes, sir. Yes.
I like that. Done then?
Yes, sir. If nobody
Yes,
else
sir.
has doubts,
Yes.
we'll conclude, sir.
Yes, yes. Done.
Yes.
Thank you, sir. Thank you very much.
Thank you. Thank you,
Thank
sir.
you
No
so
problem.
much, sir.
Great, great.
Thank you.
Thank
No
you so
problem.
much.
See you around. Bye, bye.
Bye.